I'm your host, Dr. Spencer Nadolsky, and with me, I have the amazing Dr. Fariha Bhatti. She's our Associate Medical Director, and she works very closely with me, helping me with protocols and policies. And she's an all-star when it comes to patient care. Today, we're going to be talking about something called metabolic syndrome, which you may have, whoever's listening, may have heard of this, but it's something that doesn't get talked about enough and probably diagnosed enough. So welcome to the podcast, Dr. Bhatti.
Thank you so much, and thank you for your kind words.
Yeah. Well, they're well deserved. So we've been actually having some meetings about metabolic syndrome because it's not going diagnosed as much, and we're noticing maybe some insurances do approve some of the GLP-1 medicines, the ones that aren't approved for obesity, but for type 2 diabetes. Sometimes they approve it when somebody has metabolic syndrome. So we wanted to go over what it is, why it matters, what to do about it, and that type of thing. So why don't you give a brief introduction about metabolic syndrome? What are the components and what does it even mean?
Yeah, sure. So as Spencer mentioned, we get this question a lot about metabolic syndrome and why it's important. And it's basically a constellation of physiological abnormalities that are important because if a person is both overweight or obese, and they also have metabolic syndrome, it can actually increase their risk for diabetes, and it can increase their risk for cardiovascular disease as well. So basically, when we look at metabolic syndrome, it's defined by the main groups that really define it are the NCEP, the National Cholesterol Education Program, and then also the World Health Organization. And they define it kind of similar. They're basically looking at abdominal circumference, the circumference of your, the waist circumference, and then your triglyceride levels, your HDL levels, which is your good cholesterol, and also in terms of your fasting blood glucose, and then your blood pressure as well. So all of these are very important, and they have different criteria. Some are defined for like men and women differently, but they're important because again, all of these together, if you have three or more of these, it can definitely, that is what is defined as metabolic syndrome. So that collectively then increases your risk of cardiovascular disease and diabetes as well.
Yeah. So they put this cluster of the syndrome together, this cluster of characteristics together, because the underlying issue is like this insulin resistance. So insulin has a few things that goes on in your body. Everybody knows it as getting your glucose into your cells. So you eat some sort of carbohydrate, whether it's an apple or bread or anything, and your pancreas detects the glucose, and then we're like, well, the glucose needs to get in your cells to be used, so your pancreas secretes this stuff called insulin, and it's kind of like a key that unlocks, I always say, the little sugar trucks in your muscles and fat cells to come out and get the sugar, to bring it inside and to use. And you have insulin resistance, you still secrete or make that insulin, but then the sugar trucks don't come out, whether the battery's dead. There's many analogies we can use, but the insulin's not working as well. So your pancreas puts more and more insulin out. And some of the factors that occur are some of these things with metabolic syndrome. So some people get elevated blood pressures from insulin resistance. There's the triglycerides start going up, the HDLs start going down because of the enzymes are resistant to the insulin. And then, of course, your blood sugars start to creep up as your insulin doesn't work as well. And so, like as Dr. Bhatti says, it's an interesting thing because, some people may say some of these things are a little bit elevated. Your blood pressure is a little bit elevated, but you're good. Your blood sugar's slightly elevated, but you don't have type 2 diabetes. Your triglycerides are a little bit high, but who cares? Your HDL is a little bit low. And they probably don't even measure your waist circumference. They'll look at your BMI, and you could have a normal, quote unquote normal BMI, but then a slightly elevated waist circumference. But the thing is, if you have this cluster of things, which are kind of subclinical, as some people might put it, as Dr. Bhatti says, it puts you at a massive increased risk of cardiovascular disease, heart attacks, and then also developing the type 2 diabetes. So what are the specific cutoffs? Let's start with blood pressure, for example.
Yeah, so for blood pressure, mostly we see 130 over 85, and then we also, the World Health Organization defines it as 140 over 90.
That's
So,
interesting. They have
yeah,
different cutoffs.
yeah. But I mean, for the most part, I think everyone typically just uses 130 over 85.
Yeah.
Mm.
Do they now? You can hold. It's I maybe they differ, but like you can have one or the other. Is that right, or do you have to have both diastolic, the bottom number, and the systolic, the top number, or does one component count for it?
So it's usually it's coupled together.
Hmm.
One, yeah.
So if you had a 130 over 80, that wouldn't count.
No, but I mean, again, ideally, so the idea is to have our members and for patients in general to have this checked in, like, over periodically over some time, to have repeat values, because that's what's going to give the most accurate indication.
Yeah.
And it's actually recommended to have to be checked for all these different parts of metabolic syndrome like every 3 years, which many primary care physicians don't do currently, but it's really important for patients to have that checked.
Okay. So we got the blood pressure, and then what about the glucose, the sugar?
Yeah, so for again, the difference is um, the one that's widely used is a fasting blood glucose greater than or equal to 100. And then for the World Health Organizations, it's 110. But obviously, we want to be more cautious than not. So,
Yeah. I think so. Yeah. So most people know like the 100 or even 110 over in across the pond over in Europe. I think they use that for even a diagnosis of pre-diabetes.
mhm.
Um, and then with 126 and above being type 2 diabetes. But yeah, 100. So yeah, some doctors might be like, yeah, it's a little bit high. And there are some people that might just get a spurious level. Like there's certain hormones in the morning, growth hormone and cortisol, and these things even when you're fasting, that can cause it to be elevated and you don't actually have insulin resistance. But that's why they cluster all these things together to see. Okay, triglyceride levels,
Yes, 150, which
150 milligrams per deciliter. Got it.
exactly. And that's normally what's flagged on lab values,
Yeah,
anyway.
so that one's pretty easy. I will say that anybody with like 100 milligrams per deciliter and above probably starting to see some insulin resistance, but they make the cutoff at 150 to keep it standardized, and there's something called specificity and sensitivity that they make this cutoff because that's where the most bang for the buck is without having false positives.
Mhm.
Maybe they'll change in the future. I don't know. All right. So what about the HDL, the high density lipoprotein cholesterol?
Right. So the good cholesterol, so that would be 40. So we actually want that to be high. So if it's less than 40 in men or less than 50 in female and women.
Yeah. And so the reason it's interesting, part of this has to do with the female, the women hormones that people know, like estrogen, these types of things. Postmenopausal women, their HDL levels start to decline. So women tend to have higher HDL levels in general. So they have um, a higher cutoff actually,
Mhm.
because if it's below 50 for them, that's not normal. Whereas guys, it's like no, you can be in 40. Although if you're in the 40s, even if you're a guy, like um, that's not. It's probably showing some signs of insulin resistance, but they created that cutoff there. Okay,
Wow.
so then what about the waist circumference?
Right. So for waist circumference, it's 40 inches for men and 35 for women. But the interesting thing about this, sorry, excuse me. But the interesting thing about this is that it's also, there are some differences between races and then also, or ethnicities, and also in terms of between, again, comparing to the World Health Organization, their cutoff is more of like a combined average. So
Hmm.
whereas the Biden guidelines just does centimeters and difference between men and women, the World Health Organization does 94 centimeters, for instance, for both.
Yeah, it's interesting. So yeah, different ethnicities. So for example, like South Asians, we all have different thresholds of when we start developing type 2 diabetes and risk for cardiovascular disease. And different ethnicities, they have a lower threshold than, say, like Caucasian. So uh, that's why we see these lower, like if you have a little bit higher fat, just even though it would be fine on a Caucasian, it wouldn't develop those abnormalities on average, mind you. You would start developing these abnormalities. So that's why there can be different cutoffs. But in general, 35 inches for women, 40 for men. I would probably do the ethnic cutoffs if we really want to get down into the nitty gritty. The BMI is the same thing. Like, even though the FDA guidelines are like a 27 plus comorbidities, we could probably go down to something like a 24. But FDA doesn't, they don't differentiate right now. I think in the future we will, we'll start seeing those types of things. What could you describe how to actually do a waist circumference? So it's not your pant size.
No, it's not. So that's done. There are different ways to do it, but typically you can do like 2 inches above the navel and use like a, what's it called, a measuring tape, basically.
Yeah, like I don't know, like a cloth tape. So yeah, I usually have people like feel the tops of their hip bones. Basically, you feel that hard part, and then you want to go like parallel to the ground, because like if you start going all over the place, it's not going to be accurate. This is one of those things. It's hard to get accurate measures on. We're going to start doing it with our patients, and we have to do a little tutorial video. But we are worried about having just wide inaccuracies about this, because I noticed clinicians don't even necessarily do it correctly in the office either, or you have to get a medical assistant, to do it before you see him. So we're going to do a nice little tutorial to make sure that everybody does it right. And it'll be optional anyway. You won't have to do it. But the reason we're doing this and talking about this today is because insurances, they know that this will, improving this will improve outcomes. So that's why they're starting to pay for these more expensive drugs. They don't want to just give it to everybody. So, okay. So let's say you have you have 3 of the 5. You could have 5 of the 5, 4 of the 5, or 3 of the 5. If you only have 2 of the 5s, you technically don't have metabolic syndrome. So, like for example, if you have your blood pressure is like that, and your waist circumference is a little bit elevated, but your HDL and your triglycerides and your glucose are normal, you technically, if you only have 2, you wouldn't have metabolic syndrome. So, what if you do get diagnosed with metabolic syndrome? Like, what do you do about it? I mean, I think we know the answer, but we'll just talk about it, I guess.
Yeah, I mean, so as I mentioned in the beginning, the biggest thing is the one thing that's tied to all of these issues, right, is weight. Because as your weight increases, in fact, like the number one way to even lower your blood pressure is to lose weight. So if you look at everything individually, which you do have to address individually in order to reduce the risks of both cardiovascular disease or getting to become diabetic, you have to address each thing individually. So I wouldn't say the easiest, but the way that you can do that and address all of them together is to lose weight.
Yeah.
Basically going to address all of them.
Yeah, I think that's a good point. Because, like, okay, so for example, if your blood pressure, if you start treating each of these separately, let's say your blood pressure is high, you're like, okay, take a blood pressure medicine. We have a bunch of different ones. You take an ACE inhibitor, a calcium channel blocker, whatever it is. And then you're like, okay, hey, your triglycerides are a little bit high. We have drugs for that. They're, statins and fibrates and different things. All right, we'll add that. There aren't really good drugs for increasing HDL. There's niacin, but that doesn't really actually improve outcomes, but whatever. And then glucose, let's give you some metformin or something like that. So we could address, let's say, 3 of them separately, but the underlying cause is that excess fat or adipose tissue, usually abdominally stored. That's why they use the waist circumference. And if we can help reduce that one thing, it would improve all the cluster of symptoms in general, unless one of those components that you had was just kind of like a genetic thing. Like sometimes blood pressure doesn't improve with weight loss necessarily, but if they're all related, then the weight loss. So, I mean, for us specifically at Sequence, we utilize a lot of GLP-1 medicines, but we also have dietitians and strength coaches that would also potentially improve some of those markers outside of just weight. Along with the GLP-1 will help with the weight and whatever, but like some of the dietary patterns can help with some of those lipid improvements. and then the strength training and gaining muscle and stuff like that, and aerobic training could help with the blood pressure too. So all those things are important. Um, how aggressive? I mean, like when you see somebody with metabolic syndrome, are you being more aggressive with like, hey, we need to lose weight faster, or anything else like that, or is it more one of these things like, hey, if this is a risk factor, I think it's something we should just, I don't know, be more aggressive with this person, or is it just like, okay, let's hopefully we can just get insurance to pay for it? What do you feel like?
So no, I definitely feel more aggressive and more passionate about treating those patients.
Yeah.
Even when they did the studies and they looked at, like, so we mentioned obviously 5 things that go into metabolic syndrome, but the abdominal circumference that you mentioned, and in addition to that, and the insulin resistance, those are the 2 big ones that can really expedite this process. And so we want to make sure that we tackle those right away. And even in terms of pre-diabetes, like we have, patients who might be like come with pre-diabetes, and a lot of patients don't realize that 80% of people who have pre-diabetes become diabetic within 5 years. So it's something we definitely don't want it to escalate. And again, that insulin resistance is really what causes that vascular inflammation. It causes all of those, the endothelial dysfunction, like basically the vessel dysfunction.
Mm-hmm.
That ends up leading to cardiovascular disease. So I would say, interestingly, if a patient even has obesity but they don't have metabolic syndrome, the risk factors are, much, much less, right, for any kind of sequela that happens later on. Whereas if a patient has metabolic syndrome, but their weight might not be as high, but they are either overweight or obese, that's definitely a higher priority.
Yeah. It kind of goes into the idea of like we want to do staging or clinically diagnosing of obesity as opposed to being BMI centric or anthropometric centric, like using just body measures. Because even if you use like body fat percentages, you can still technically have like a metabolically healthy obesity, which is at a much lower risk than somebody who's metabolically unhealthy who has these components of metabolic syndrome. So the idea is probably need to be more aggressive with these people that are at higher risk. And the people, it's not that we don't want to treat the other people. It's just that like, hey, these people need to do it like now, as opposed to, the wait and see type of approach. So yeah, I agree with that. I think we're going to see insurances start to go like, hey, maybe we should, maybe we'll approve it for this patient, but maybe wait for this other patient. Yeah, there's lots of different things there, because the thought is that maybe we would want to prevent them from developing the metabolic syndrome, but like, I don't know. It's lots of interesting discussion there, and I don't think we have the exact answer, but I agree. I think being more aggressive there. Anything else you want the listeners to know? I mean, I think we went over. I think for me, I would say like, hey, if you're like, hey, I think I have all those things, I should probably put that as a diagnosis, and I might be able to get better coverage of these medicines. Anything else you want to add?
No, I think we really discussed everything. I mean, mostly again, not to scare any members or potential patients, but the biggest thing is the risk, right? So the risk factor, like the risk definitely increases for cardiovascular disease by, twofold, and for diabetes by tenfold if a patient has
Yeah.
metabolic syndrome. So it's not something we want patients to sit on. Like,
Yeah, I agree. It's not one of these things like, it's a little bit past normal. You'll be okay. It's like, well, these clusters together really increase the risk. Well, thanks for coming on, Dr. Bhatti. It's always good to chat with you and share your expertise with the rest of the Sequence community. And if you're listening to this and you have a friend or family member that you think could benefit from this, make sure you share it with them. Thanks for listening.